Excellent, excellent. I'm very honored to have the opportunity to teach you or to talk to you a little about Alzheimer's disease, which is my favorite topic. Because of the way the Zoom is organized, I don't think I can look at the chat during my talk. So if you could put questions in the chat as you go along, I will be delighted to answer them at the end. I also don't have a hard stop at 9 o'clock if we need to go a little past. So we can feel free to take our time. My disclosures are mostly that I do quite a bit of research and I get a mix of support from different sources, including the National Institute on Aging, some foundations, and some industry support. I do consulting to industry mostly on trial design and interpreting the results of trials, and I'm on one data safety monitoring board, and I don't own any stock. I'll talk about dementia, Alzheimer's, a bit about epidemiology, a bit about psychiatric symptoms, because I'm a psychiatrist, and the current state of treatments, both those that are approved for use and those that are in the research pipeline. To summarize, Alzheimer's is the commonest dementia. It has a huge public health footprint, a lot of patient and caregiver burden. It is largely a disease of aging, and as healthcare in Uganda improves and people live longer, you will see more Alzheimer's disease. The best way not to get Alzheimer's disease is to die young. That's a joke, but that's actually kind of true. We think we know a lot about the mechanisms, but really what we're discovering is that it's not a single mechanism. We've probably been lumping together several different diseases. A lot of cognitive and psychiatric symptoms. It tends to progress slowly. A lot of the work that's being done is in biomarkers. There are now PET scans, both for amyloid and tau, and you can also look for them in body fluids. It's been studied the most in cerebrospinal fluid, but honestly, the blood-based biomarkers have truly taken off in the last couple of years. And I think in a few years, we're going to be doing entirely blood-based biomarkers. Our current medication treatments are not very effective, and to be honest, although the pipeline has quite a few drugs in it, not exactly sure where to place my bets for hope for the future. Sorry that this was my numbers are US-centric. 5.4 million in the USA, 20 million worldwide, and everything's going to triple by 2050. Most of the people in the world that have dementia are in India and China. Sorry to be US-centric here. US costs of $300 billion a year for healthcare costs and over 200 in the unpaid care. The thing that's cool is if we could just slow it down by 5 years, we can cut the burden in half. So we only need a drug that's pretty good or an intervention that's pretty good to make a difference. The caregiver is the customer. There is a huge burden on families. This burden can be emotional. People feel frustrated, guilty, and the family may have lost their independence because they have to do care. And there are very substantial financial costs, mostly unpaid work. You take care of your family, you don't get a wage for it, but also having to remove your participation in the workforce and sometimes long-term care. Caregivers also delay getting medical care. They may be ill and not know it. These numbers are rough, but in general, we think about 2/3 of dementia is Alzheimer's disease, and then the next ones are vascular and mixed. The borderlines between these top three are not very clear. Less common is dementia with Lewy bodies. Less common are frontotemporal lobe dementias. And there's a new one called late that I'll discuss later. Tends to be found in older persons. Stages, a lot of words on this slide, but let me just go through them quickly. MCI, mild cognitive preclinical at the top, are people that have amyloid in their brain but have no symptoms. And we call these preclinical Alzheimer's. And in general, it's a research concept. We think they're at risk of getting dementia. We have some evidence for it, but it's not for sure. MCI is mild cognitive impairment. They have subjective and objective cognitive complaints, but they're functioning fine. We used to say they had no deficits in functioning. Now we find they have a little. They're living independently, and they can be very worried. In mild dementia, they're starting to have deficits in functioning, watch for driving and other safety issues. Mini mentals, they tend to be independent in their activities of daily living. Mini mental state exam 18 to 26 is a good guess. Language is intact, and they really appear normal unless you test them. Moderate dementia, they're starting to have deficits in language and in praxis. ADLs vary, the mini mental 10 to 18. I call these folks lights on, nobody home. They're usually living with family or in an institution. Severe dementia, you don't need any of our degrees to know what it is. They're obviously impaired. They have global deficits in cognition, and they're often institutionalized. Alzheimer's disease. The main thing about Alzheimer's, it has a slow time course. There's a long stage before you have a deficits, preclinical dementia and early clinical symptoms of MCI. It has a gradual onset and a slow progression. Characteristic signs and symptoms, we call this a cortical dementia. The 4 A's: amnesia, aphasia, agnosia, apraxia. They have a functional decline, and they may have psychiatric symptoms. I'm going to tell you more about this in a minute. Memory. Episodic recall is what it's affected early. It's not what happened 50 years ago. It's what happened minutes, hours, days ago. It requires encoding. You have to encode what's going on and later on retrieval. Alzheimer's starts with a deficit in encoding, and that tends to be characteristic of the early stages, probably associated with hippocampal damage. Note that when you do a mini mental, the retrieval, the memory, may only be 15 or 30 seconds, but it's sufficient to pick up deficits in Alzheimer's. Aphasia tends to come later, often starts with word-finding deficits. You can test it looking at category or letter fluency, and later on people have comprehension deficits. Agnosia is hard to measure. Agnosia means you can look at something and you can't recognize what it is. It's often manifested by disorientation. Someone is home, perhaps in the home they've lived in for 50 years, and at 4 p.m. they become disoriented and say, "Take me home, take me home." It's a cognitive symptom. Apraxia means it's hard to turn a thought into a behavior. It's particularly noticeable in instrumental activities of daily living. Couples that come up often are housekeeping and home maintenance. These 3 A's tend to come later in disease, and usually people are at a moderate stage when these start to happen. I'm sorry my slides are so U.S.-centric. I hope they're applicable to Uganda. In the U.S., because people drive a lot and often need to drive to function during the day, it tends to be the first IADL that's affected. You might get lost. You might have poor traffic judgment. You might have motor vehicle tickets. You might have MVAs, motor vehicle accidents. Fortunately, getting lost tends to be the first symptom. You may have troubles with bill paying. I always find it quaint that I write problems balancing checkbook. I don't know what it's like in Uganda, but in the U.S., most people do their banking online and let the bank balance for them. Problems tracking bills. You get the bills, perhaps in the mail. You can't remember where you put them. Cooking is a great memory symptom. People lose track of time or of the sequence or use the wrong ingredients. If you think about it, if you were baking a bread, you might need flour, sugar, water, yeast, salt. What happens if you get the flour and the sugar mixed up? What happens if you forget the yeast? That's the kind of thing that happens in early dementia. Keeping track of appointments. There's a lot of ways to do it these days, both on paper and using a smartphone, but you have to remember how you did it. And I have many patients, you walk in their house and they've got a calendar, they've got little post-it notes, and they have a phone dinging away, giving them all kinds of reminders. But the point is, they're not using one, they're using everything at once, and they get confused. The most sensitive function is work, because it generally takes cognition. And so people who are working, you often learn they're getting demented early on. There are psychiatric symptoms. I'm not going to read all these to you, but they're very common in Alzheimer's disease. Most people, if they live long enough, will have at least one of these symptoms. The ones that are of particular note: delusions and hallucinations, agitation and depression, anxiety, and apathy are particularly noticeable. Depression's part of a spectrum of neuropsychiatric disturbance. Compared to young people, people tend to be more agitated, more delusional, and more anxious. They have decreased motivation and pleasure, but they have less of the severe depression symptoms: guilt, self-deprecation, suicidal ideation, or changes in sleep and mood. You can tell this is an old slide because I wrote DSM-4, but DSM-5 also does not capture this range. Agitation is a really wide-ranging word, a lot of different things. It disturbs caregivers. It's often worse in the evening. We call it sundowning, although we're not really sure that it has anything to do with the sun. I have a colleague who's from Iceland, and of course, in the winter above the Arctic Circle, the sun does not rise. And I asked him, do Alzheimer's patients get agitated in the evening? He says, yep, got nothing to do with the sundowning, but it has to do with the time of day and circadian rhythm. Agitation may be associated with delirium. A lot of things can happen. They may pace, shout, beseech, help me, wander. The main thing about agitation is if you're talking about it, you need to define it better so you can treat it. You need to be specific. Some slides from the National Institute on Aging in the U.S. Alzheimer's has a complicated neurobiology. Changes in amyloid beta protein are the first detectable changes. Tau protein changes come later on, but really you need to have tau changes before you have symptoms. Inflammation and oxidative stress have important roles in Alzheimer's disease. So, pretty pictures. This is what, on pathology, on an autopsy, this is what plaques look like. They are extracellular conglomerations of beta amyloid. They're dense deposits of protein, and they're quite insoluble. And notice this here, here's an Alzheimer's slide, and here's a healthy slide. And these are extracellular deposits called senile plaques. Tangles are different. They're inside the cells, and they build up inside the cells. They are actually abnormally phosphorylated tau protein, and all of these things here, all these things here are intracellular tau. Once again, it seems that you need tau before you have symptoms. Amyloid seems to be necessary, but not sufficient to cause disease. This cartoon is always hard to go through. Amyloid starts as a monomer, a single molecule, and it conglomerates into oligomers, which are generally 4 to 12 monomers. And they probably have quite a lot of effects on their own. And then eventually, including synaptic deficits, these oligomers then become huge conglomerations called plaques, and they lead to downstream tau accumulation, which are tangles. Amyloid starts with a protein called amyloid precursor protein, and it can be metabolized by an enzyme called alpha secretase or beta secretase. They all get cut by gamma secretase. And if you start with alpha, you go to a 40 amino acid peptide. And if you start with beta, you go to a 42. And to make it a long story short, 42 is bad and 40 is probably good. In the CSF, you actually see decreased 42. It's probably because the amyloid is being deposited in tangles. Once it gets to here's the oligomers, and then here are the senile plaques, which have over 1,000 monomers. You can on PET you can see the senile plaques, so you can sort of see the end stage with PET scans. And this is just a cartoon of some of the downstream events. What happens after the plaques? Why do people get disease? The first thing is there's neuronal and synaptic dysfunction, and the neurons are sick before they're dead, and the oligomers may well help make them sick. You can measure that with metabolic PET, which is FDG PET. If you're familiar with cancer staging, this is widely used clinically in cancer staging, but can also be used in studying dementias. The neurons die, and you can see that on MRI. You can see loss of whole brain volume, you can see thinner cortex, and you see smaller hippocampi. And actually, the smaller hippocampi is probably one of the best markers of early disease. Inflammation is hard to measure. I could give you a whole lecture on it, but I'd simply say if we could measure it well, we could treat it. We haven't made much progress yet in treating neuroinflammation, but we think it's an important step. Risk factors: age, and age. Here you go. If you're 65 to 74, you got a 5% prevalence. Greater than 85, 35% prevalence. It's really not much comfort to realize it maxes out at around 50%. Less education, but it needs to be education early in life, before you're 30 probably. The ApoE4 allele is a genetic mutation, a genetic allelotype. It increases risk, but it is not causative. There's a long list of new candidate genes, about 30 to 40. Each adds a small amount of risk, and many are involved with inflammation and cell-cell signaling. I don't think we're going to be using genetics clinically much these days in the clinic. We're using it a lot in research because particularly E4 seems to modulate the response to many drugs. Since I work in the US, less exercise is a huge public health problem and is probably a risk factor for Alzheimer's. All the cardiac risk factors, obesity, high cholesterol, and high blood pressure are associated with later dementia, but it's the midlife risk factors that cause late life dementia. And hearing loss is a risk factor. There's a substantial heritability risk. Most people have what's called sporadic Alzheimer's, but there's a rare autosomal dominant versions. And E4, as I said before, increases risk but is not causative. And that's what I want to say there. MRI findings. You see volume loss in the whole brain, in the hippocampus, in the entorhinal cortex, posterior cingulate, and cortical thinning. And there are various ways to measure this. Usually the radiologist can tell you about hippocampal volume. That's what I look for on the MRI. It's the best marker of disease severity. It comes later in the sequence than amyloid deposition, though. And this is just a graph that shows you these are hippocampal volumes divided between different quartiles. Here's the first quartile, the largest volume, and here's the fourth quartile, the smallest volume, and smaller and then this is the chance of remaining not demented. So you can see that the smaller hippocampal volumes are associated with a much more rapid progression to dementia over a 3-year period. Here's FDG PET, and the reason I'm picking this in autosomal Alzheimer's is these are folks that you know are very likely to get Alzheimer's, so the gene is very high penetrance, and here they are. And also, it happens that for each gene, you usually have a characteristic age of onset. By the way, it's usually pretty young, like in your 40s. So here's a patient who's asymptomatic. By the way, whoever's got sound there, if you could all mute your microphones, there's a lot of sound on there. Thank you. And in PET, bright colors tend to mean good metabolism, and this is the patient who has no symptoms. You see a lot of red and yellow, good metabolism. Here they are 3 years later, they're symptomatic, and you see a lot more blue. You see a lot less red. They have decreased metabolism in their temporal and parietal cortices, and this is the characteristic pattern for Alzheimer's. There are now several PET agents that image amyloid, and just want to check, can you still hear me? Everybody can hear me?
Yes, we can. Yes, we can.
Excellent, good. Here's a patient with mild Alzheimer's and a mini-mental of 24, and they're lighting up a lot. There's a lot of amyloid in that brain. Look at all the red. Look at all the green. Look at all, well, mostly the red. Interestingly enough, you don't really see it in the hippocampus because it's too fine-grained. You generally see most of it in the frontal cortex. Here's an 82-year-old with a mini-mental of 30 who's normal, and there's much less amyloid uptake. They were approved by the U.S. Food and Drug Administration in 2012. Medicare, which is the major payer, insurance payer for older Americans, denied coverage the next year, saying they didn't have a good clinical reason to do these expensive scans, and we're still trying to figure out where they might have important clinical value. In Alzheimer's, the amyloid is being deposited 15 to 20 years before the first symptom. This slide combines several pieces of data. The first one here is the prevalence of Alzheimer's. Notice it goes steeply up with age and gets to about 50% in your late 90s. Here are autopsy studies showing the prevalence of plaques in healthy controls, people who don't have any symptoms. Notice that the curves are perfectly parallel and there's a separation between them. And here's also the prevalence of amyloid on PET scan, which closely parallels the prevalence of plaques in the brain. The difference is about 15 years, and we think there's probably a 15-year window where we're depositing amyloid but don't have any symptoms yet. It's spooky. Could be happening to me right now. It's also an opportunity for prevention studies, which we're doing right now. CSF changes, you see decreased amyloid beta because we think it's going into plaques. Increased tau, it is sensitive but not highly specific. And these days, because it's covered by insurance reimbursement, if I need to know the biomarkers in a patient, I will do CSF. I'm a psychiatrist, so a neurologist does the lumbar puncture. Tau, phosphorylated tau, is a major component of neurofibrillary tangles, less likely than A beta to be specific to Alzheimer's. There's a lot of overlap with frontotemporal dementia. CSF is much more useful, and total tau is increased in Alzheimer's. Phospho-tau is more sensitive and specific than total tau. And tau can be phosphorylated at many sites. I'll go into that a little later. And we now have some tau PET imaging agents. Just, you don't have to look at the details here, but just to say they exist. And they here is a patient who's got lots and lots of amyloid all over the brain. And in the tau, what you're seeing here is specific parts of the brain, particularly the temporal cortex. And tau has a characteristic a pattern of progression through the brain. Blood-based biomarkers. Let's have a blood test for Alzheimer's. We want markers that are less expensive than PET. PET in the U.S. costs $5,000 to $8,000 easily, and less invasive than CSF. It's been a very long project, but about 2 years ago, things really came to a head in a good way. And we're now seeing a lot of tau results, and phosphorylated tau 181 and 217. They correlate well with tau in the brain. The amazing thing is they also correlate with amyloid. These may not just be chemical markers of tau, but maybe physiologic markers of the disease. And there's a bit of an arms race to decide which of the phosphorylated tau epitopes is going to be the best biomarker. So there's the possibility that we may have a blood test for Alzheimer's. The performance of these blood-based biomarkers is not bad right now. It's not quite as good as CSF and PET, but it seems to be getting there. Dementia with Lewy bodies, it's kind of a cross between Alzheimer's and Parkinson's. Fluctuating cognition and consciousness. They have a cortical dementia. They have a mild Parkinsonism that's poorly responsive to levodopa. They're very sensitive to extrapyramidal symptoms from antipsychotics, and they have vivid visual hallucinations. The pathology is different. There's Lewy bodies in many areas of the cortex, as opposed to Parkinson's, where they're restricted to the basal ganglia. Sorry, let me go through. How do you tell it from Alzheimer's? Well, there's vivid visual hallucinations, fluctuating cognition, and prominent Parkinsonism. In terms of Parkinson's, in DLB, the dementia comes first and is a cortical dementia with amnesia as the early symptom, whereas in Parkinson's, they tend to have executive dysfunction first. The visual hallucinations are very vivid in dementia with Lewy bodies, whereas in Parkinson's, they tend to be related to to levodopa use. There's a new dementia on the block, late limbic predominant age-related TDP-43 encephalopathy. But suffice it to say, it's a new dementia, really defined just about 3 years ago. It's TDP-43 was formerly identified in many frontotemporal dementias, but this is a one that appears like Alzheimer's but is pathologically different. It tends to affect characteristic areas of the brain: amygdala, hippocampus, and middle frontal gyrus. Shares hippocampus with Alzheimer's, but the other ones are not affected much by amyloid. Clinically, it's really identical to Alzheimer's. You can't tell the difference. And in terms of demented adults who are old, it's a very common dementia. In general, amyloid burden is so prevalent in the oldest patients that it's no longer a risk factor for dementia, but vascular risk factors are. The main thing you should know about pathology is that pure dementia pathology is the exception, not the rule. I won't go through the details here, but suffice it to say, in a large autopsy series from the United Kingdom, they were looking at who had a pure pathology and who had a mixed pathology. There were some pure Alzheimer's pathology and a little bit of FTD, but no pure cases of DLB, vascular dementia, or late. And most people had more than one pathology. Take-home lessons. Dementia has a huge public health burden. Alzheimer's is most common, but the majority of dementias are mixed. Memory is commonly affected early in dementias. Neuropsychiatric symptoms are very common. We understand the prodromes better with biomarkers, and we may soon have a blood test for Alzheimer's. Current treatments basically can be summed up as the medication treatments can be summed up as disappointing. I personally use cholinesterase inhibitors at all stages. You got to watch for gastrointestinal side effects, and you've got to watch for bradycardia. And I find memantine, the data are only good for moderate severe Alzheimer's, and I find it even more disappointing. So I use these drugs, but without an enormous amount of enthusiasm. They have a great concept. There's decreased cholinergic innervation all over the brain in Alzheimer's, and they prolong the effect of acetylcholine. Adverse events: nausea, diarrhea, nightmares, and there's a patch for one of them, Exelon, which has fewer GI side effects. They're maddening because they have a very consistent but rather small effect. Here's a mini mental. The y-axis is the mini mental. And here's a six-month study, 24 weeks, and mini mental increased by 1.5 points. Is that a lot or a little? Good question. I would say for some patients, it's a much larger improvement and they really notice the improvement. Others don't seem to notice it. It's really a question of whether this effect is clinically relevant. It varies from person to person. And there's a lot on this slide, but I would say the meta-analysis suggests that the effect sizes for efficacy are small to moderate. This is called a standardized mean difference, very similar to a Cohen's d. And in general, you'd like to see 0.5 and up. You don't really see it here. You see anywhere from 0.03, which is minimal, to 0.38. And certainly you see a lot of side effects, but not mortality. There are risks. I'm particularly concerned about bradycardia. It doubles the incidence, but most importantly, this is a hazard ratio for syncope, pacemaker placement, hip fracture. It's pretty significant. I'm going to skip the details on memantine because it's just not that useful. I would say here's a meta-analysis which favors memantine for cognition in mild to moderate Alzheimer's, and the effect sizes are just pretty small. Here's a 0.14, here's a 0.12. So once again, I use these drugs without enormous enthusiasm. Bottom line, cholinesterase inhibitors have a consistent effect throughout the Alzheimer's spectrum, but it's a modest effect. Clinical impact is varied. I tend to try one or two. Careful of bradycardia falls and fractures. Memantine, only effective in later AD stages, similar effect size, and it's a pretty benign drug. New drugs on the horizon targeting amyloid. There's been a lot of studies of antibodies that target amyloid and tau. I would say they've been studied since around the time we got amyloid PET. There are many null results, and they cause a fair number of side effects. We call these ARIAs, amyloid-related imaging abnormalities. They include vasogenic edema and microhemorrhages. They are mostly asymptomatic, but rarely cause prolonged neurologic signs and symptoms. In recent years, there have been 3 antibodies targeting the plaques themselves that have somewhat better results, but still I'm not sure are going to be very useful. I'm not going to go through the major political controversy about aducanumab. Let's just say there was some statistically significant clinical effects and robust removal of amyloid, but there was a positive study and a negative study. And the FDA approved the drug anyway, and there was a lot of controversy about whether this was a good idea. In the US, Medicare recently declined to reimburse. This is important because the costs were very substantial, over $50,000 a year for the drug alone. And if you include the intravenous therapies and the necessary MRIs, could go up to $100,000. It was similarly rejected by the European Medical Agency and by Health Canada. There are 2 other antibodies coming on the horizon, donanemab and lecanemab. I think they're similar. They're a bit better at removing amyloid, and we'll see how strong the effects are. To date, the anti-tau antibody trials have been largely null. It's not entirely a surprise because antibodies barely get into the brain, and tau is intracellular. So the question is, can antibodies get into the cell? I'm not sure that we know how we're going to target tau at this point. There are a lot of small molecules that affect tau synthesis. We've yet to see clinical results. Let me talk about lifestyle interventions, because this is, I would think, where the real hope for preventing Alzheimer's is, and I think we're already making progress. So exercise. These are all epidemiologic studies. Aerobic exercise is associated with a lower risk of dementia in a lot of studies, sometimes associated with increased hippocampal volume. The trial's results are just trickling in, and they are varied. There's a large US trial of aerobic exercise where we're eagerly awaiting the results. So this is an example where epidemiology points to a strong effect, and now we're doing trials to see how strong that effect really is. Cognitive rehabilitation. I feel cognitive rehabilitation is a lot like the concept of happy adolescence. It's a great idea if you can come up with it. There are many companies selling you cognitive rehabilitation, at least in the US. It fits in with education being protective. I'll be honest, I'm not sure we know how to do it. I'm not sure that the brain, once damaged, actually rehabilitates. It's a question of how much plasticity there is. Can you rewire the brain to do the same function with the functioning brain? There's a impressive but inconsistent literature on the association of late life depression with cognitive decline. Actually, one study suggesting SSRIs are protective. I'm doing a clinical trial of psychotherapy in MCI plus depression, and there have been no prevention trials to date. So this is an interesting target because we always want to treat depression, but it may actually, treating late life depression may also prevent dementia. Hearing might be the most promising target. Sorry, I've got a lot of Hopkins people on here. Hearing loss is associated with MCI and dementia, and we've got two friends at Hopkins. One is doing a worldwide trial of hearing aids to improve cognition, and I've got a colleague who has also found vestibular dysfunction in Alzheimer's and is doing a trial of vestibular therapy. Neuropsychiatric symptoms. Just give you an idea of the problem behaviors: uncooperativeness, combativeness, refusal of redirection, wandering, hitting, tearfulness, beseeching, yelling, profanity, verbal aggression, pacing, trying to escape, hoarding objects, and repetitive behaviors. Also apathy and loss of interest, social withdrawal. And just give you an idea of the kind of causes: delirium. Other people, I think it's March 3rd, my good friend and colleague Karen Neufeld will talk to you about delirium. Delirium means cognitive changes from a medical problem or a medication. Common causes are UTI, pain, dehydration, and many, many medications can make old people delirious. Anticholinergics, benzodiazepines, opioids, and slow increases in drug levels. Another cause of disturbance is cognitive impairment, particularly disorientation and sundowning, or frustration with functional deficits. They may have a recurrence of a depression or a psychotic disorder, but more importantly, more commonly, they have a depression or a psychotic disorder associated with Alzheimer's itself. They may have the wrong level of care, the wrong amount of care, or you may have changed their environment and they're having difficulties with transition. They may have unsophisticated caregiving. The caregivers may need education. Find the cause. If it's delirium, you better find the cause. Just remember, it's harder to stop medications than to start them. To start them, you just need a good idea, but to stop them, you must monitor response and be thinking about adverse events. You may need to modify the environment, educate caregivers. Is it closely linked to the cognitive impairment? Look for things that precipitate the problem behavior. Intervene early. The major behavioral intervention is distraction. Find something they like to do that is more amenable for the caregivers, and educate caregivers, and also develop new routines, activities, structure for the day. Let's see. My colleague Quincy Samus will be speaking next week. She is our home dementia care expert, and this slide is really just a one-slide summary of what she works on. So let me just mention, we have a package we call a dementia care needs assessment. We make sure the patient has primary care. Safety measures certainly have to address driving, wandering, self-harm. Certainly have to oversee medication administration. We try to give people a daily structure, including recreational activities. In the U.S., there's a system of adult daycares, which often will take care of demented patients during the day. This actually closed down during COVID and caused my patients a great deal of stress as people were locked down. And you try to find a behavioral program that plays to individuals' strengths and history. And Dr. Samus will be talking much more about that. Try to have sleep and eating routines. You may have to do a capacity evaluation to see if the patient can make their own decisions. Educate the caregiver to have a realistic expectation about diseases. Caregivers often get angry and they say, well, she just doesn't want to remember. Often this is not the case. They may need respite. They may need a break. They need help with problem solving. And they may need emotional support, because there is a kind of grief and bereavement that happens if a patient gets to advanced dementia. They're alive, but they're not who they used to be. And people are often struggling with this transition. And I don't know the laws in Uganda about decision making. In the U.S., each state has its own laws about how decision making is determined. But just suffice it to say, a lot of people with dementia can't make their own decisions. In the U.S., there are legal documents you can sign that say the power to make the decision will pass to whom I designate. Apathy is loss of motivation and interest. Can be distinguished from depression. It's a major quality of life issue for caregivers, may be related to deficient dopaminergic transmission. And I've been the principal investigator, co-principal investigator for 2 studies of methylphenidate. That's Ritalin. And it works quite well for apathy, and we're starting to use it more widely. Treatment of agitation and psychosis. You ask if medications are needed, depends how severe the agitation is, how much caregiver stress, how much interference with daily care. You want to specify the target symptoms. You particularly are looking not at delusions, but whether the delusions are troubling the patient, whether they're upsetting the patient. Medications, we're I should really revamp this slide to be in better to be more clear. We're studying SSRIs because they seem to be the safest. We have one trial that showed some efficacy for citalopram, and we are now doing a follow-on study of escitalopram, which is probably responsible for the signal we saw with citalopram. Antipsychotics, the newer agents are best tolerated. And I just mentioned risperidone, olanzapine, and Seroquel. Just notice that these are very small doses. These are the smallest doses that you can find a pill for of any of these. When things are worse, people sometimes try anticonvulsants such as Depakote, but there are quite a few side effects from Depakote. Try to avoid benzodiazepines except for emergencies, because patients often become cognitively worse, and because the blood levels of benzodiazepines tend to increase over time, and they may become ataxic and they may fall. There is a mortality risk. Our good friend Lon Schneider at University of Southern California was responsible for a meta-analysis 17 years ago, which basically showed that antipsychotics increased mortality risk. It's not a huge increase in mortality, but it certainly causes me to be more scrupulous about the use of antipsychotics, not to use them lightly, and to discuss the mortality risk with families. In general, it means I'm using antipsychotics when I'm thinking about comfort care rather than aggressive prolongation of life. I'm doing a study of cannabinoid. The people are using a lot of cannabinoids for agitation. I won't go through the details here, but I'm doing a multi-site trial of dronabinol, which happens to be a FDA-approved version of THC. It's approved for anorexia, but we're studying it for agitation. And I have a lot of friends. I probably haven't included them all here. And I thank you for listening, and I would be delighted to take your questions now. Sorry if I went a little quickly. There's an awful lot to cover. It's a broad topic. So I'd be happy to take your questions now.
Thank you so much, Professor Rosenthal, for that great talk. We now open it up for questions. And please raise your hand, put up your hand, or type your question on the chat. Professor Noeline, please go ahead. I see your hand is up. Please go ahead and ask your question or make your comment.
Thank you very much, moderator, and thank you very much, presenter Paul, for this afternoon. This has been really very educative and up to date. And I think such talks are really very important for us to keep up with what's happening elsewhere. I have 2 questions. The first one is on the issue of, how early, if at all you're going to use any of, the treatments that you've talked about, the anticholinesterase inhibitors or NMDA receptor blockers, how early is good enough, and how long should you continue with this treatment? Is it for as long as the person lives? Because you mentioned that amyloid, deposition as people grow older also increases. So when does it cease to really be of benefit? That is the first question. And then the other one I have is in regards to cognitive rehabilitation. versus brain plasticity. Is there any plasticity really that can happen with an aging brain?
Great.
Those
Thank
are
you.
my two questions.
Thank you for your very insightful questions. So the first one is having to do with medications on the market. Let me talk about them separately. So with cholinesterase inhibitors, my feeling is that they tend to have, in my patients, they tend to have the best effects quite early in disease. And so I tend to use them as soon as patients or families are bothered, or as soon as memory problems are a bother. Keep in mind, these are not disease modifying agents and they don't change the course of the disease. I'm sorry if I didn't make that clear. And so it's not related to amyloid deposition. So I tend to use them early. Stopping them is really a judgment call. I stop them if people are having I stop them if people are having side effects, particularly if they're losing weight in more advanced disease, because they can reduce your appetite. And there are some people where I continue them well into advanced disease. There is no clear stopping point. Very, 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 very real problem in this field. Memantine, I wait until people have at least moderate dementia, and I often continue it through life. The evidence is not good that they work in mild dementia. Now, as for cognitive rehabilitation, there's been a fair amount of work done on mechanisms. Let me give you an example. In mild cognitive impairment, if you many people will function well, like if you give them a memory test, they're starting to have memory problems in daily life, but they can compensate early on. They compensate by using a greater volume of brain or using different parts of their brain to solve the same problems. And we're hoping that this would work for cognitive rehabilitation. If I sound skeptical, I've not found the results very impressive. You can definitely do cognitive rehabilitation in cognitively well older people, and you can probably help them resist some of the symptoms of dementia. It's not clear if you can do anything for MCI. Let me answer let me go to the questions in the chat, and then we'll get back to people's questions in audio. Are seizures, epilepsy a challenge in cholinesterase with inhibitors? I haven't found it. I mean, it's one of those things in the fine print of the package insert, but I've not found them to lower seizure threshold significantly. Smartphone applications for screening for subclinical and mild dementia. There's a lot that's being tried. There's nothing that I can recommend yet, but I would really keep an ear to the ground for this, because a lot of people are developing simple smartphone apps for screening. Do I use combinations of dementia drugs? I combine the cholinesterase inhibitors and memantine very frequently. They have such different mechanisms of action. There's no reason not to try both, particularly in moderate dementia. I do not use two cholinesterase inhibitors at the same time. There's no reason for that. Multivitamins. Well, we're not sure of the benefit of any specific vitamins. In general, at least over here in the U.S., people often don't get a lot of sun exposure as they get older, and a very large proportion of older persons are vitamin D deficient, and we supplement. I supplement myself because I work indoors. I'm not quite sure. I haven't seen great data that it helps with cognition, certainly with a lot of other medical problems. I'm happy to take more questions.
Did you answer the second question of Professor Noelin about aging and plasticity and aging brain recover?
I did in a vague and hand-waving way. And what I meant to say is we have some evidence that there is some plasticity, that the damaged brain can compensate by using other parts of the brain to solve problems. It's not clear whether our cognitive rehabilitation treatments actually do that, and whether they give you enough plasticity to make a big difference. So I say to patients, give it a try. Don't let people charge you enormous amounts of money for it. And in my slides, and I'd be happy to share my slides with Dr. Noeline if you want to share them with the group. There's a couple in the U.S. that I'm fairly fond of. One called Lumosity and one called Brain HQ. Lumosity, they don't have much of an evidence base, but they share their data with researchers, so I'm fond of them because they help out my friends to do research. And Brain HQ has a little bit of evidence that it might be helpful in MCI.
My question to you is about race. Is there any association between Alzheimer's and race?
We're just finding out, because it's really a bit of problem in U.S. studies that so many studies are on predominantly white populations, and that's because that's who tends to come to these referral centers. Alzheimer's is commoner in, so let me just compare black and white Americans. Alzheimer's is commoner in black Americans. E4 probably has less effect in black Americans, but the thing we don't know yet is whether different treatments have different responses by race, and we're starting to see some effect of that. The National Institute of Aging is making a major push to improve the diversity in trials for this very practical reason.
Paul, while you're still at that, at the other poll, when you control for the other risk factors that you pointed out, the metabolic ones, which we know are usually a big problem in African Americans, even after you control for those, does race still, being African American still contribute to being, having Alzheimer's disease?
Yes, probably. But what you brought up is the exact problem in epidemiology. You have to first control for a ton of lifestyle and even genetic. You have to control for lifestyle and for comorbidities. Even so, there is probably race differences. When I use the word probably, it's because the important difference is do blacks and whites respond differently to different treatments? And we're just starting to get data on that. Let me answer a couple of these in the chat. Hearing loss, the question is, are deaf people more likely to develop Alzheimer's? We don't know, because our measures of cognition, it's hard to find one that works well across deaf and hearing people. I'm sorry, we don't know about that. How far can we go with ginkgo biloba? It's one of the few nutraceuticals that's gotten a good trial, and it was certainly a null trial. It didn't work at all in early Alzheimer's, so I have not been enthusiastic on it. Activities that are beneficial for Alzheimer's patients. I actually want you to come back next week and listen to Dr. Samus, who has a lot more to say about that. But I would say in general, exercise, cognitive stimulation, having a variety of leisure activities that involve socialization. I think that's the one we're getting at there, that the socialization is an important part of this. This has been a big deal during COVID because many of my patients were really locked down with just one or two family members, and they suffered greatly. What progress has been made in dealing with inflammation as a cause? Excellent question. Not much. We're really at the beginning of finding drugs, and we're not so sure about environmental and dietary factors, whether they can significantly affect inflammation. There certainly are ideas about anti-inflammatory diets, and I think they may have some merit. Problem is, we don't know how much it takes. So, for instance, many berries in the U.S., people like blueberries. They're expensive and they're delicious. Blueberries probably have anti-inflammatory effects, but we don't know how much you need to have that effect. Is it a cup? Is it a bushel? We don't know. Prophylactic medication that can be given for those at high risk of developing Alzheimer's? Well, we're doing the research on this. I'm part of two very large worldwide multi-site studies where we enroll people who are cognitively normal and have amyloid in their brain, and we think they're at risk of getting Alzheimer's, and then we are randomizing them to getting an anti-amyloid antibody versus saline. And the results are not in for those. These prevention studies have to be very long. The one that we're in the midst of right now, the patients are getting antibody for like at least 5 years. And now there's a new study with a new antibody. So that's exactly what we're doing. I'm still not sure that giving antibodies is going to ever become a widespread treatment, but I think it's a model to see if we can do prevention.
Charles, go ahead and ask your question, please.
Okay. Thank you, moderator and Dr. Paul. My questions are quite many. I'm sorry, but hope doctor will help me out. I'm found in a profession where we see patients daily, and on that factor.
Which profession is that? Please clarify.
General medicine. Yes?
Please go ahead.
Okay, so sometimes we need to teach people mostly on how to avoid, if like for those ones within 60, 70 years. So I would like doctor to help me on how we could help these people, maybe on improving their healthy lifestyles regarding avoiding Alzheimer's disease, and how living a healthy lifestyle would help someone manage Alzheimer's disease.
So let me answer that. Let me do one question at a time. So I'm going to share my slides with Noeline, and Noeline, I'm going to share with you a document that I give to patients on lifestyle interventions, and you should feel free to share it with the group because it sums up a lot of information for patients. So, Dr. Charles, briefly, it tends to be what we can do right now, what we know we can do, it tends to be cardiac health. And it's probably because we know more about treating vascular disease than about preventing Alzheimer's. So let me just mention in word, exercise, cognitive stimulation, which might work, having a variety of leisure activities that involve socialization. I did not mention sleep, but we believe that poor sleep is a risk factor for Alzheimer's. And by all means, if you have hearing loss and you can treat it, that's a good thing. And so those are, to me, that's the lifestyle interventions package. It hasn't been proven, each component hasn't been proven to work, but the studies are ongoing. And what people are doing now is worldwide there are a number of multi-factor lifestyle interventions that are being studied. Sorry, I didn't have slides on that. I didn't realize it would be interesting here.
Okay. Another question is on early diagnosis of Alzheimer's disease. We know that we have a symptomatic phase of Alzheimer's disease, but mostly people will present with this mild dementia, where mostly would think of the dementia we know. So I'm asking about which tests can be done, mostly to do with the blood tests, imagings that can.
Okay, so what I do in the clinic is I find that the history is the most important thing, and it is essential that I have an informant. It's not just the patient. I need someone who knows the patient well. That's because if they have memory problems, they may not be able to report their own symptoms very accurately. So I need an informant, most often a family member. I take a history, and for Alzheimer's, the most characteristic history is problems with short-term recall that are starting to affect day-to-day functioning. Then I do an office test, and I'm sorry, I should have spiffed up these slides to talk about the office tests. In the US, I'm using the Mini-Mental or the Montreal Cognitive Assessment. They might have some challenges in Uganda because you're dealing with a very wide range of education, and those tests tend to be biased downward by low education. So you might score poorly on the Mini-Mental and not actually have dementia. I recently helped our colleagues, including Noeline, put in a grant to study these things in Uganda, trying to find the best test. In terms of blood tests, I'm really looking for routine things that could mimic Alzheimer's. B12 deficiency, hypernatremia, severe dehydration, hypercalcemia, and of course, renal dysfunction and liver dysfunction. All of those might mimic a cognitive impairment. I don't know how available imaging is for you. If MRIs are available, they're by far the best imaging sequence you can do. They can do what are called coronal sequences, and coronals will help you look at the hippocampal size. And I think that's the most important screening that you can do. So that's what I do in the office. With unusual cases, particularly people who are very young, I will try to get biomarkers. Usually that involves a lumbar puncture and looking at CSF, amyloid, and tau. I really don't think this is necessary for garden variety Alzheimer's, but I think for unusual or atypical cases, it might be quite useful.
Okay, thank you, Doctor. Then the last question is on treatment. I've seen in your slides where there is cholinesterase inhibitors as one of the treatment methods. So I'm asking, can it also be used as a pre-treatment method?
No. There's no evidence that the cholinesterase inhibitors are. Oh, I'm going to put words in your mouth. They're not. There's no evidence that they prevent future dementia. They're a symptomatic treatment for current symptoms. So I don't use them in people who have no symptoms, but I do tend to use them in people who have early symptoms. So people who come in with mini-mentals in, let's say, the low 20s and they have memory problems, that's who I particularly use cholinesterase inhibitors in.
Because, Doctor, I believe cholinesterase inhibitors, they can also help either in talk of regenerating nerve cells.
No, they don't help regenerate nerve cells. Sorry. If they did, we'd be much more excited about them. We are still looking for a really good disease modifying. What you're getting at here is the difference between a symptomatic treatment, like cholinesterase inhibitors, and a disease modifying treatment. As I said earlier, these new anti-amyloid antibodies have some evidence of disease modification, but I personally don't think they're very strong, and I don't think they're going to take over because I don't think that the risks are going to be worth the limited benefits. I think we need better drugs.
Okay. Thank you, Professor. Those are all my questions that I had.
Thank you, Professor.
Thank you for those excellent questions.
Yes, thank you, Professor Rosenberg. I think we have come to the end of our session. I would like to thank you so much for a very engaging presentation. And I also thank the participants for the active participation. And I think you believe that you agree with the excellent questions. So we come to the end of our session.